Hello everyone. So today's lecture is on children with special healthcare needs too. So in this lecture we will be discussing about the medical conditions or the medically compromised children and the dental treatment and how do we manage such type of medically compromised children in the dental situation. So the intended learning outcomes. At the end of the lecture, you will be able to classify the special child, discuss in details about the medical and dental management of physical mental disorders, recognize the most frequently seen craniofacial malformations or syndrome found in children of Malaysia. So the most commonly the first we'll be discussing about the respiratory diseases. Among the respiratory diseases, the most commonly seen are the asthma. So the asthma is a chronic airway disease characterized by inflammation, and in asthma what do you see? There is a diffuse of obstructive or obstruction of the airway which is caused by the edema of the mucous membrane. So the mucous membrane in the airway it gets edematous or inflamed, and there is increased mucus secretion and spasm of the smooth muscles. So asthma is a common childhood disease affecting 1 in every 10 children. So the exposure to irritants may be because of the increased sensitivity to allergen or bronchial hyperactivity. If a person or a child is sensitive to cold air, dust, pollen, anxiety, stress of the dental clinic or the dental scenario, the incidence being 5 to 10% of the children. So the signs and symptoms that what we see are of mild, moderate type and severe types. So in the mild or moderate types we have breathlessness, wheezing, coughing, while in severe the child might have intense dyspnea, that is difficulty in breathing or shortness of breath, cyanosis of the mucous membrane and the nail beds because of the reduced amount of oxygen reaching into the mucous membrane and the nail beds, then minimal breath sounds, then there is flushing of the face that you see, and extreme anxiety of patients in severe cases. So moving on to the oral manifestation of children with asthma is high caries. This high caries rate is because of the decreased flow of saliva, and which causes or which leads to, because there is decreased flow of saliva, so the oral clearance of the medication that the child takes in as nebulizers is reduced, and that leads to high caries. There is also increased prevalence of oral mucosal changes characteristic of chronic mouth breathers. Because these children are chronic mouth breathers, you will have the oral mucosal changes like increased level of gingivitis, then which again the chronic mouth breathers will have posterior crossbite and increased overjet and increased facial height. So all these are the oral manifestations of a child suffering with asthma. So moving on to the dental treatment and prevention. So a child who is suffering from or who is asthmatic, so how a dental treatment should be given to the child, and what are the prevention or preventive methods that the child and the dentist should undertake while treating a medically compromised child. So in this, so if a child who comes to the dentist or who comes to you for a dental treatment, you need to first take a complete medical history of the child. You need to assess the child's risk of acute exacerbation or anaphylaxis during the treatment prior to examination. So you need to ask the child about the detailed question about his asthma history or the frequency. If it is more than 2 per week, indicates that it has poor control, and severity, that is previous hospitalization or any emergency room visit, triggering agents, management or medication. So these are the things that we need to ask the patient before we start any dental treatment. Then confirm that the child has taken most recent dose of medication. If the child is on any medication, then we have to confirm if the child has taken the medication or not. Then we have to administer bronchodilators as pre-medication before dental treatment may be used, because this reduces the bronchospasm or difficulty in breathing, this again reduces that. So if a child is symptomatic during the treatment, it's always better to reschedule the appointment than doing the treatment. So reschedule symptomatic children who are coughing or wheezing if appropriate. So behavior methods are employed to reduce the anxiety. So anxiety being one of the factors that increases, or that triggering factors for asthma. So it's always better to do some amount of behavior modification in these children that will reduce their anxiety, and hence will reduce the chances of asthmatic attack of these children in the dental clinic. Then the use of nitrous oxide analgesia is appropriate for patients with mild to moderate asthma, but it is contraindicated during episodes of wheezing. Then caution is advised for patients with severe asthma. So if a patient who is suffering with severe asthma, it is always, there's a lot of caution that the patient has to take care of. Then it's always better to consult a physician than treating the patient. Some of the dental materials that we use can also exaggerate the asthma, including the dentrifices that we use, or the fissure sealants, or any tooth enamel dust while tooth cutting, or crown preparation, or methyl methacrylate, fluoride trays, cotton rolls. All of these can exacerbate the asthmatic attack, so it's always better to avoid all these things. Then the next that we should preventive measure is have supplemental oxygen available during the treatment in case there is an acute asthmatic exacerbation. Monitoring breathing and avoid obstructive airway. So you should always, when you're treating an asthmatic patient, always monitor the breathing of the patient and avoid obstructing the airway. Rubber dam will decrease the chance of particulate inhalation. So we need to use rubber dam because this will reduce the chance of inhalation of the particulate by the patient, and hence reduce the chances of asthma. Then consider prescribing fluoride rinses to use at home to reduce the caries incidence, especially for children using beta-2 agonists. So if a child is using beta-2 agonists, then he should be prescribed with fluoride rinses or dentrifices, so that this will help in reduction of caries. So this is a at-home technique of reducing caries. So positioning a child with mild asthmatic symptoms in an upright or semi-upright position for dental procedure is always beneficial. So it's always better to make the patient sit upright or semi-upright, but not in supine position for the dental procedures. So moving on to what are the steps or initial management, how do you do for a patient with acute asthma attack in a dental surgery, during a dental surgery. That is, first calm and reassure the patient. Then you need to stop all the dental procedures, sit the patient upright. So it's always better to make the patient upright, so this will help in his breathing. Administer 100% oxygen to the patient. Then administer patient's own medication with 5 milligram salbutamol nebulizer. So if a patient has come with his own nebulizers, it's it's good if the dentist asks the patient to get his own medication and nebulizers, so that if there's any attack at the time of the dental treatment, he can use it. And the last is monitoring of the vital signs. So if the signs and symptoms of asthmatic attack are relieved, then good. So send the patient. It's always better not to continue with the treatment on that same day. You can recall the patient and do the treatment in further appointments. So if the signs and symptoms continue, then give the 0.3 ml 1 is 2000 epinephrine IM or subcutaneous IV line. Then start theophylline or call for assistance. So now we move on to the heart diseases. In heart diseases, we'll be discussing about the infective endocarditis. So infective endocarditis is characterized by microbial infection of the heart valves. So the heart valves are infected with the microbes or the endocardium in proximity to the congenital or acquired cardiac defects. So if a child is having a congenital or acquired cardiac defects, so these microorganisms come and infect the heart valves. So which are these microorganisms? So they are the Staphylococcus, group A Streptococcus and Pneumococcus, which attacks a normal heart. Poor oral hygiene may give rise to frequent bacteremia under normal physiological conditions, leading to a permanent risk of developing the disease. So you need to maintain a good oral hygiene. So poor oral hygiene will cause increase in risk of bacteremia. That will again lead to permanent risk or more chances of occurrence of the disease, that is infective endocarditis. What are the clinical symptoms that we see in the patient who are suffering from infective endocarditis? They have low irregular fever. The fever mostly occurs in the afternoon or evening peaks with sweating. There will be malaise, anorexia, that is loss of weight, and arthralgia, muscle pain. So there will be inflammation of the endocardium, increases the cardiac destruction. So once there is an inflammation, the bacterium coming and attacking the heart valves, so that will cause inflammation of the heart muscles, that will cause, that in turn causes the cardiac destruction, and murmurs subsequently may develop. Painful fingers and toes and skin lesions are seen in infective endocarditis. So these are few recommendations for endocarditis prophylaxis. So endocarditis prophylaxis recommended and not recommended. So these are the few mentioned things that a child who is suffering from infective endocarditis, he needs prophylaxis or he does not need prophylaxis. So depending upon the dental treatment that you are going to provide it to the child. So if prophylaxis is needed, if you are doing dental extraction, any periodontal surgery, scaling, root planing, probing, placement of dental implants, reimplantation of avulsed teeth, endodontic surgery or instrumentation beyond the apex, subgingival placement of antibiotic fibers and strips, initial placement of orthodontic bands but not the brackets, intraligamentary local anesthetic injections. The endocarditis prophylaxis is not recommended if you are doing any restorative treatment or restorative dentistry without any use of retraction cords, local anesthetic injections, intracanal endodontic treatment, post placement and build up, placement of rubber dam, post operative suture removal, placement of removable prosthodontic or orthodontic appliances, taking of oral impressions, shedding of primary teeth. So these are the few recommendations that you should remember, that a child or a patient suffering with infective endocarditis, so he needs prophylaxis for which treatment, and he does not need prophylaxis for which all the treatments. So the antibiotic prophylaxis that we have discussed in the previous slide is what we have mentioned. So antibiotic prophylaxis regime for dental procedures. So either you give oral or you give IV or IM. So we have mentioned about the agents that we use for adults and for children. So if the medication is given oral and it is amoxicillin, for adults it is 2 grams, while for children it is only 15 milligrams per kg. If the patient is unable to take amoxicillin, then the next drug is ampicillin. Or if the patient is allergic to the NSAIDs or penicillins, or if the patient is unable to take or is allergic to penicillins, then cefazolin or ceftriaxone can be given. So ampicillin for adults it is 2 grams IM or IV. For children it is 50 milligrams per kg IM or IV can be given. Cefazolin or ceftriaxone is 1 grams IM or IV can be given. IM is intramuscular, IV is intravenous, or 50 milligrams per kg intramuscular or IV. If the patient is allergic to penicillin or ampicillin, then cephalexin or clindamycin or azithromycin or clarithromycin can be given. So if it is cephalexin or clindamycin, it is 2 grams for adults, 50 milligrams per kg for children. Then clindamycin is 600 grams for adults. For children it is 50 milligrams per kg. Azithro or clarithromycin is 500 grams for adults and 15 milligrams per kg. If the patient is allergic to penicillin or ampicillin, unable to take oral medication, then cefazolin or ceftriaxone or clindamycin can be given. So cefazolin or ceftriaxone is 1 gram IM or IV can be given in adults, 50 milligrams per kg IM or IV for children, while clindamycin 600 milligrams IM or IV, and in children it is 20 milligrams per kg IM or IV. So moving on to the management of children with infective endocarditis. So you need to first obtain a thorough medical and dental history at each visit, due to because they are at the risk of infective endocarditis. So you need to have a thorough medical and dental history of these patients. So discuss the dental treatment with patient's primary physician or the cardiologist. So you need to discuss the treatment that you will be doing as a dentist with the physician, general physician or the child's physician or the cardiologist. Behavior management techniques are useful, and conscious sedation and nitrous oxide analgesia are actually useful or beneficial in reducing the anxiety in such patients. And if general anesthesia is indicated, the treatment should be done in a hospital setting with adequate supportive care is available if needed. The dental considerations. So pulp therapy is not recommended for primary tooth with a poor prognosis. So if a primary tooth with poor prognosis is need to be treated, then pulp therapy is not indicated in such cases, because there are chances of high incidence of associated chronic infection with the infected tooth. It's always better to extract the teeth, extract the infected tooth with appropriate fixed space maintainers. Endodontic therapy in permanent dentition can usually be accomplished if the tooth that is selected and treated if the tooth is carefully selected and treated, and the endodontic therapy is adequately performed, so then it will be a success for endodontic treatment in permanent dentition. A dentist who feels uncomfortable in treating such type of patients, medically compromised patients, and who are susceptible who are susceptible to infective endocarditis, they're responsible to refer the patient to a person or to a dentist who has an idea or regarding this. And sorry, I think there is a typing mistake here. So what are the preventive strategies that needs to be followed? Education of parents or the caregivers is a critical for ensuring appropriate and regular supervisions of daily oral hygiene. So brushing needs to be done with a fluoridated toothpaste twice daily, should be emphasized, which helps prevent caries and gingivitis. A non-carcinogenic diet should be or discussed for a long time prevention of any dental diseases. And oral side effects, example like xerostomia, gingival overgrowth of medication should be reviewed. So all these medication with oral side effects like xerostomia and gingival overgrowth should be reviewed. The diet needs to be checked that the child is not having a carcinogenic diet, and brushing with fluoridated toothpaste twice daily with that will help prevent dental caries and gingivitis. So moving on to the next disorder or this next system is the renal or the kidney disorder or the renal disorders. So renal disorders in children occur as because of familial or hereditary disorders and developmental disorders. The common renal disorders that are seen in children include any congenital nephropathies, nephrotic syndrome, chronic renal failure, glomerulonephritis, hydronephrosis, multicystic renal dysplasias. Children usually show retarded growth and they have a tendency to bleed due to the capillary being fragile. Capillary fragility and thrombocytopenia is positive, and the child is pale and anemic. So the pediatric significance, the oral manifestation that we see is generalized pallor of the oral mucosa because these children are suffering from anemia. There is tendency to bleed and slightly prolonged bleeding due to impaired platelet adhesion. Chronic marginal gingivitis due to excessive urea in the blood. Bony lesions can be seen in the jaws. Hypoplastic teeth and tetracycline discoloration because of the medications that they take. So moving on to next, which is epilepsy. Epilepsy is a chronic neurological condition which is characterized by recurrent unprovoked seizures. Occurrence of at least 2 unprovoked seizures 24 hours apart. So the epilepsy is mostly associated with the neurological condition. So epileptic seizures, the clinical manifestation of abnormal or excessive discharge of a set of neurons in the brain. So the seizure is because of the abnormal or excessive discharge of the neurons in the brain. So there are types of epilepsy, which is grand mal seen in adults, petit mal seen in children, and absent seizures. What are the considerations for dental management of epileptic patients? So in this we have a lot of management, how we need to manage a child in the, with epileptic attack in the dental clinic. So the most important factor being for an epileptic attack is the stress. So stress being one of the factor that can trigger a seizure. So appointments should be scheduled during a day during the time of the day when the seizures are less likely to occur. So before you start any treatment, you need to take a complete history of the seizures, when the seizures occur, what is the time duration. So once you obtain the history, then you will be able to manage the patient. So first, reducing the stress in the dental situation, then after that the appointment is important. So you need to schedule the appointment at that time of the day where the seizures are less likely to occur, and you need to minimize the stress and anxiety during the appointment. So the next thing is you have to explain the dental procedure to the patient before you start the treatment, and you need to adhere to whatever treatment you have explained to the child. You cannot shift from whatever you have explained to the child and then you move on doing something else, because this again will increase the anxiety and hence trigger a seizure. So explain the dental procedure to the patient before starting, and offering assurance and supporting the procedures are always useful. Then the next, light can be one of the triggering factors for an epileptic seizure. So you need to see that you do not place, or either you give a dark or a colored glasses to protect the child's eye, which is one of the triggering factor of the seizure, or do not focus the light on the child's eye, and the light should be directed into the patient's mouth only and not flashed onto the eyes of the child. The use of conscious sedation and general anesthesia is not contraindicated with patient with epilepsy. So a patient with epilepsy, you can either treat the patient under conscious sedation or general anesthesia. So seizures, first aid in the dental office. So if a patient gets a seizure during the treatment in the dental office, so how you need to manage. So if a seizure occurs while a patient is in the dental chair, clear away all the instrument from the patient. You need to remove all the instrument away, sharp instruments away from the patient, and place the dental chair in a supported supine position as near to the floor as possible. So you need to place the chair down and in as near and close to the floor as possible, and it should be in the supine position. Place the patient head on his side or her side. So either you place the patient in the sideways, not in the to decrease the chances of aspiration of any secretion or any dental materials in the patient's mouth. So once you place put the chair down, and then you need to place the patient on the sideways, so this will reduce the chances of aspiration of the secretions or any dental materials. Then do not restrain the patient. Do not put finger in his or her mouth. So if you put your finger, you might be bitten because of the seizure, uncontrollable seizure. And you need to time the seizure. The duration of the event may seem longer than it actually is. So you need to time the seizure, because you need to give the history, or once you send the patient to the for the emergency, you need to provide the information about the time and the duration of this seizure. So once the seizure is over, once the patient has got the seizure is over, you need to do not undertake further dental treatments that day. So you need to give another appointment or reschedule the appointment, and do not continue with any other treatment for that day. Then try to talk to the patient to evaluate the level of consciousness during the post-ictal phase. So the post-ictal phase is after the seizure is over. So that's the post-ictal phase. You try to talk to the patient and analyze about his level of consciousness, and then only let him go. Do not attempt to restrain the patient as he or she might be confused. So the child is already confused, and if you try to restrain him during the seizure time, so once his seizure is over, he will be in a state of confusion or shock that why are you holding or restraining his body. Do not allow the patient to leave the office if his or her level of awareness is not fully restored. So if a patient is not fully restored or fully aware or is not fully conscious, then you should not leave the patient, leave the dental office. Contacts the patient's family if he or she is alone. So this is for adults. A child cannot come alone to the dental clinic, so this is generally for adult patients. Do a brief oral examination of sustained injury. So you need to examine but not do any treatment. So do a brief oral examination of if the child has sustained any injuries. So depending upon the post-ictal state, discharge the patient home with a responsible person and to his her family physician or to an emergency room for further assessment. So depending upon how the patient is in the post-ictal state or the seizure is over, you need to discharge. Either the patient can go back home, or he can go and meet his family physician, or to an emergency room for further assistance. That all depends upon his post-ictal state. So now we move on to the endocrine disorders, and in endocrine we will be discussing about diabetes mellitus. So diabetes mellitus is a group of metabolic diseases which is characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both. So in this, what happens in diabetes mellitus, there is increased secretion or there is hyperglycemia resulting in defects in insulin secretion. So either there is defect in the insulin secretion or insulin action, or maybe both. So the diabetes mellitus can be of two types, that is type 1 and type 2. Type 1 is in children, that is younger than 40 years of age, while type 2 is old age. So type 1 is sudden onset, usually affecting person younger than 40 years. While type 2 is the one which is most common of the two types, slow on onset. The symptoms affect the obese persons usually older than 40 years. So the glycemic control is important to prevent any systemic complications such as eye, kidney, heart and periodontal disease. So you need to control the glycemic index. So there shouldn't be any hyperglycemia or hypoglycemic, so that again will cause other systemic complications, like it can affect the eye, it can affect the kidney, it can affect the heart or the periodontal diseases. Unstable diabetes can exacerbate any periodontal and diseases and cause blood glucose to rise. So if a patient is having unstable diabetes, then it can exacerbate whatever periodontal disease the patient is suffering. It can increase the periodontal disease and can cause blood glucose level to rise. So what we will be discussing about the blood glucose range. So a normal range, this is what is for children, that is for the normal range is 3.9 to 5.9 millimoles per liter. The fasting plasma glucose is more than 7 millimoles per liter, while the plasma glucose more than 11.1 at 2 hours after a 75 grams oral glucose load. So what are the manifestations that we see? So there is polydipsia, that is increase in thirst, polyuria, that is increased urination, polyphagia, that is increased appetite. There will be weight loss despite the patient having increased appetite, that is polyphagia. Children with type 1 diabetes often present with diabetic ketoacidosis, that is hyperglycemia associated with ketoacidosis. The high incidence of severe complications including diabetic ketoacidosis and other autoimmune disease are Graves' disease, Hashimoto's thyroiditis and Addison's disease. So your high or if the patient is if the severe complications will lead to Graves' disease, Hashimoto's disease or Addison's disease. So moving on to the medical management of a diabetic patient is intensive treatment programs and comprehensive education in self-management has to be done. So these self-management and comprehensive education includes your diet control, exercise and frequent self-monitoring of the blood glucose. So diet control, that is reducing the high carbs, increasing the protein, less of the balance has to be maintained in the diet. Frequent exercise needs to be done, and then frequent monitoring of the blood glucose level to see if there is any decrease or increase in the blood glucose. So the advice that we need to give to a patient who is diabetic is you assess for glycemic control by asking questions about the patient's lifestyle. You need to assess what is a patient's lifestyle, then how often the blood glucose is monitored, what forms of treatment has been prescribed for the same. Ask about the condition of the oral soft tissue, like dry cracked lips, dry mouth, burning inflamed mucosa, bleeding, poor wound healing, candidiasis. All these are indicative of the glycemic control of the patient. The patient with uncontrolled diabetes may require medication with an antibiotic before dental treatment. So a patient who has uncontrolled diabetes, he will require medication post any dental treatment because he is more prone to infection. Then you need to prescribe mouth rinses and chlorhexidine to reduce the infection in such patients and reduce the bacteria from the mouth. So what are the dental management? You need to first take a history, medical and dental history of the patient. After that, once the appointment is given and patient is recalled, the appointment should be given in the mornings. For morning appointments, the patient has to eat and take his medications normally how he generally takes, and the patient should not skip his breakfast and come for the treatment. Then there are chances of hypoglycemia to occur in the patient during the treatment. So type 1 diabetes is managed with insulin as well as dietary changes and exercise. So type 1 is the one which is seen in children, so it should be managed with insulin as well as dietary changes and some form of exercise. So during treatment, if the child becomes hypoglycemic and shows symptoms of restlessness, yawning or slurred speech, the next stage what the child may go is into coma or loss of consciousness. So in this we need to, how do we manage this patient? 2 spoonfuls of sugar in water should be given, and this again will make the sugar level, blood glucose level normal. So the few symptoms that we should notice as a dentist while treating such patient is the restlessness of the child, if the child is yawning, if the child has slurred speech. Then the next stages will be coma and loss of consciousness. So during treatment, the most common complications of diabetes mellitus is hypoglycemic episode. So the initial signs and symptoms will include mood changes, hunger, weakness, followed by seating incoherence and tachycardia. And if this is untreated, or if this is not treated, then possible consequences may include then hypotension, hypothermia, seizure, coma, and the last will be death. So after treatment, the patients are at a greater risk of developing infection, and they may demonstrate delayed wound healing. Therefore, you need to provide a good antibiotic coverage is necessary to prevent it from delayed wound healing and infection. So a number of oral conditions have been associated with poorly controlled diabetes mellitus, which include periodontal diseases. So in periodontal diseases, that is gingivitis, heavy calculus deposition can be seen, severe pocketing and loss of bony support, and periodontal abscesses if in patients with poorly controlled diabetes mellitus. Salivary gland dysfunction is what we see is xerostomia and caries can be seen. Fungal infections, which is oral candidiasis, oral burning and taste alteration. This is again due to xerostomia, lichen planus, and lichenoid reactions may be seen in higher type of in type 2. So it is most commonly seen in type 2 diabetes mellitus, that is lichen planus and lichenoid reactions. Then traumatic ulcers and irritation fibromas, this is related to altered wound healing patterns. So moving on to the dental treatment of patients suffering from diabetes mellitus is conservative treatment, that is any septic teeth which cannot be easily restored to a non-septic condition. So a tooth which is infected and cannot be restored to or cannot be where the infection cannot be reduced, and non-vital teeth which cannot be properly supervised are better removed. So a tooth which cannot be the infection cannot be reduced, or it is non-vital and cannot be supervised, so it is always better to remove such teeth because they are the source of infection and so the periodontal treatment scaling may need to be carried out frequently and must be thorough, though as non-traumatic as possible. So scaling has to be carried out frequently and it should be thoroughly done. No irritation with the calculus or no leftover calculus should be there, and non-traumatic as possible. Instructions in correct toothbrushing and gum massage should be given to the patient. The appliances, there is no contraindication to orthodontic treatment, though you have to regularly supervise such type of children, and special care has to be given, especially in children for brushing and massaging the gums, because once they are wearing the orthodontic brackets and the oral flushing of the food debris and the plaque reduces, and you need to take special care in brushing and massaging the gums. So moving to the oral surgery that can be done, so extraction but under local anesthesia usually creates no special problems in diabetic children under good insulin control. So a child who is in good insulin control and the extraction is done under local anesthesia, there will be no problems, or it will not cause any problem for the in such children. So the patient's normal insulin and meal regime has to be followed, and that he has not had any recent signs of sugar instability, that again we need to know. So if the patient's recent sugar instability is not there, and if the patient's normal insulin and meal has been taken or followed, then the treatment can be done. General anesthesia should never be used in diabetic patient as an outpatient in dental surgery, because this again would require fasting for at least 3 hours before the operation, and would most certainly precipitate insulin shock. So general anesthesia should not be never be used in diabetic patient. The reason being 3 hours of fasting the child has to do, and this can precipitate insulin shock. Any extraction which is accompanied with some degree of infection should be supported with antibiotic coverage to give the tissue additional help in combating the infection. So if extraction is done but there is some infection related to the same tooth, so an antibiotic coverage has to be given. Haemoglobinopathies or hemophilia, it is a disorder of hemostasis resulting from a deficiency of a procoagulant. It is an inherited bleeding disorder. Approximately 1 in every 7,500 males are the one who are affected. Hemophilia is a heritable X-linked deficiency of plasma factor. So the low factor 8, that is hemophilia A, low factor 9 is hemophilia B, that is Christmas disease, and levels on assay, these are the ones which it causes. So it's a sex-linked recessive characteristic transmitted by asymptomatic female carriers and manifest only in male. So the hemophilia can manifest, it's an X-linked disorder, so it manifests only males while females are carriers. And this disorder is because of the deficiency of the procoagulant. So it's also called as the royal disease. Queen Victoria of England was a carrier of hemophilia gene and subsequently passed the disease on to several royal family members. So this is the history that we know about the hemophilia. So hemophilia types are type A, that is hemophilia A, B and C. Hemophilia A, which is the classic hemophilia, because this is because of the deficiency of factor 8 and it's an X-linked recessive. Hemophilia B is called as Christmas disease and this is because of the deficiency of factor 9. Again, this is an X-linked recessive. While hemophilia C, which is the Rosenthal disease, it is called as Rosenthal disease, and this is because of the plasma thromboplastin antecedent of factor 11 deficiency, and it is an autosomal recessive disorder. The clinical manifestation that we see is this pain due to hemorrhage into the spaces, that is the intracranial hemorrhage is the life-threatening type of hemorrhage. Then hemarthrosis, that is swelling of the joints. There is non-functional joint, there will be swelling of the joint and hence this will lead to the patient will not be able to bend his knees. Then excessive bleeding after trauma will be seen. Hemorrhage seem to stop immediately after trauma as a result of normal vascular and platelet response, but after more than 1 hour bleeding starts and persists. So you'll also see serotumors. So these serotumors, as you can see in the picture, there is a hemorrhagic what are serotumors? There is a hemorrhagic serocyst, subperiosteal bleeding with reactive new bone formation, which leads to tumor-like expansion of the bone. As you can see, one of the jaws of the child is expanded. So this is because of the reactive new bone formation, which leads to tumor-like expansion of the bone. Hematomas are also seen, that is hemorrhage into the subcutaneous tissues, internal organs and joints is a common feature, and these leads to hematomas. So hematomas are hemorrhage into the subcutaneous tissues or internal organs. The orofacial manifestations that we see is gingival bleed even on routine dental care. So even if you are just doing an oral examination, the child may have severe bleeding from the gums or the gingiva. There is severe prolonged bleed even during the physiologic processes, even when normal physiological processes, like if the child is brushing, he might see bleeding gums, physiological processes like tooth eruption and exfoliation. Generally in exfoliation, when the primary teeth exfoliate, it's not normal exfoliation, there is no bleeding that occurs, but in hemophilic patients there is severe prolonged bleeding that occurs. Even while tooth eruption, there is no bleeding that we see normally, but in hemophilic patient we have excessive bleeding. Then recurrent epistaxis. So epistaxis is bleeding from the nose. So you will the patient will have recurrent bleeding from the nose, and spontaneous mucosal bleeds will also be there. So we have read about the hemophilia. Next we will be discussing of the von Willebrand's disease. This again, it comes under the blood disorders, and then we will in total we will be discussing about the treatment or the management of hemoglobinopathies. So now we move on to the von Willebrand's disease. It's a dominantly inherited, complex and variable condition which is characterized by vascular abnormality. There's vascular abnormality of the large capillaries, defective platelets and decreased level of factor VIII. So in von Willebrand's, it's a complex thing. What you see is there is abnormality of the large capillaries, there is defective platelets and decreased level of factor VIII. The main function is in platelet adhesion to form platelet plugs. Impaired function leads to bleeding from the skin and mucosa and bruising. So the main function of a platelet, how bleeding does not, in a normal person bleeding does not occur, or the platelet plug formation reduces the blood flow. So this function is impaired. So the platelet adhesion function to form a platelet plug is impaired, which leads to bleeding from the skin, mucosa and bruising. So the symptoms that we see is nose bleeding or spontaneous gingival hemorrhage. So the pain management is for both, that is hemophilia and von Willebrand's disease. So how do you manage the pain? And the first is analgesia. Analgesics containing aspirin or anti-inflammatory agents like ibuprofen may affect platelet function and should be avoided. So anti-inflammatory agents or aspirin or ibuprofen, this should be avoided. Because they affect the platelet function, and since there is already defect in the platelet and there is no platelet plug formation, so again analgesics and anti-inflammatory should be avoided. The local anesthesia is infiltration. Anesthesia may generally be administered, so you can administer infiltration as anesthesia. Inferior alveolar nerve block and posterior superior alveolar nerve block are the ones which predispose to formation of hematomas, so which potentially cause airway obstruction and create life threatening bleeding episodes. So when you're giving inferior alveolar nerve block and posterior superior alveolar nerve block, you have to be very careful and you need to do aspiration all the 4 planes before you give the infiltrate or give the anesthesia, because if it is not done properly, there might be chances of hematoma formation, which is more common in posterior superior alveolar nerve block. And if once there is hematoma, so which will lead to airway obstruction, and again which might be a life threatening bleeding episode might also be seen. So the prevention of diseases, first is prevention of diseases. How do you prevent dental diseases? Is by prevention of by application of topical or systemic fluorides at regular intervals, by brushing twice daily with a fluoridated toothpaste. So you need to use topical or systemic fluoride at regular intervals, brushing twice daily with a fluoride toothpaste, regular use of mouth rinses and floss for plaque control, consumption of proper diet and professional examination at regular intervals, and rubber cup prophylaxis and supragingival scaling. So these are few of the preventive management or treatment that needs to be followed by these patients. So the prevention of bleeding, the treatment should be started after consultation with the hematologist. So any treatment with any medical condition, so you need to consult the child's family physician or the specialist. So here we need to first consult the patient's hematologist. Once we consult with the hematologist, then we can proceed with the treatment. So knowledge of factors, levels and replacement requirements are necessary. So what are the dental management that we can do? So in scaling and periodontal diseases, in case of inflammation, supragingival scaling should be done first, and subgingival scaling only if mandatory. If it is not required, we do not need to do, because this again is the source of bleeding that can the patient will have. Use of manual pressure while can be used, and the use of tranexamic acid or oral mouth wash can and other factors or replacement therapy can be used to control bleeding. So tranexamic acid is the one which reduces the bleeding or stops the bleeding. So this you can use as a mouthwash, or oral mouthwash can be used as a replacement therapy to control the bleeding. So in restorative procedures, conservative extension of the gingival margins has to be done, which you have to see that you do not injure the soft tissue. Conservative treatment or extension of the margins of the restoration needs to be done. Interdental wedges minimize the gingival trauma and open intraproximal contacts, so there will be less amount of trauma or injury to the tissues. Crown preparation which enter into the gingival sulcus may be preceded by mechanical tissue packs or reflect gingival tissues temporarily. So if a crown preparation that needs to be done and the crown needs to go into the gingival sulcus, then mechanical tissue packs can be done so that you reflect the tissue away from the tooth surface, and you can easily then prepare the tooth and place the crown and minimize the tissue injury. High speed saliva ejectors can be used, but with caution. Endodontic therapy, that is proposed technique for rubber dam application in patients with bleeding disorders. So never put the rubber dam subgingivally or below the the rubber dam should not injure the soft tissue. As you can see here in the second picture, that is showing tight fit of the rubber dam prongs onto the tooth surface. So the prongs are touching the tooth surface without injuring the gingiva, and can prevent the need for extractions. That is, pulpotomy or pulpectomy is preferable to extraction. So it is always preferable to do the pulpectomy or pulpotomy than to extract, because there will be again lot of bleeding in extraction. Rubber dam application is mandatory. Avoid over instrumentation, that is, avoid instrumentation beyond the apex during endodontic treatment. Any orthodontic or prosthodontic treatment, it is safe to be done in patients with hemophilia. Both interceptive and full banded orthodontics can be performed. No sharp edges of wires to prevent laceration of the oral mucosa. So you need to see that once you place the bands, there are no sharp edges of wires that can will injure the oral mucosa. Oral hygiene has to be maintained, because that will avoid because it is important to avoid the inflammation, edematous and hemorrhagic gingival tissue. Impression making, that is use of plastic trays or lines. So if you're taking any impression, you either use plastic trays or line the borders of the tray with wax so that it does not lacerate the mucosa of the patient. Extraction and dentoalveolar surgery in patients with hemophilia. The best that can be done is rubber band extraction. So this is least invasive, less amount of bleeding from the site. Block anesthesia should be avoided. So before we move on to the other things, so what is rubber band extraction? So a rubber band is placed or slipped onto the tooth, and then this rubber band slips to the cervical region. The rubber band is placed on the tooth and it slips into the cervical area, and it causes with time, as it moves down towards the root, this will cause severance of the periodontal ligaments and hence least amount of bleeding. So the next is block anesthesia should be avoided. Ideally, all necessary surgery should be done at the time of the one operation. So any one operation, any other treatment that needs to be done should be done in one to avoid multiple visits of the patient and to avoid the bleeding. Then surgery with minimal trauma needs to be done. Suturing is needed to stabilize the gum flap. You need to suture the flap to stabilize it, and use non-traumatic needles. Minimize the number of sutures, as we have already discussed. Use of resorbable suture so that you do not have to recall the patient for removing it, and again bleeding source. Then pack the socket with Surgicel. Soft and cold diet for 5 to 10 days, and the medication that needs to be given is oral penicillin, that is 250 milligrams, or amoxicillin 500 mg for 7 days. So any emergency treatment like acute pulpitis or abscess with facial swellings, if not possible, urgent referrals to a specialist pediatric unit is required, as use of sedation or general anesthesia may be indicated. So, and if a tooth is non-restorable, temporary sedative dressing. If the tooth is non-restorable, then it is better to just provide temporary sedative dressing, and once the pain reduces, then you can extract it. So moving on to the viral hepatitis. So viral hepatitis is caused because of the inflammation of the liver cells, which may lead to necrosis or cirrhosis of the liver. Acute hepatitis can present as the lethargy, loss of appetite of the patient, nausea, vomiting, abdominal pain, and jaundice. Acute viral hepatitis may be caused of the following, any of the following, like hepatitis A, that is HAV, hepatitis B, which is HBV, and hepatitis delta virus, and the two non-forms of non-A and non-B hepatitis. So acute viral hepatitis may be because of the A, B, D, and the two non-forms, that is the non-A, non-B hepatitis virus. HAV is the hepatitis A virus, is spread by the fecal oral route, while the HBV is transmitted from person to person by parenteral, percutaneous, or mucous membrane inoculation. So today we will be mostly discussing about the HBV and very little about the HAV. HBV, as it is transmitted from person to person because of the parenteral or percutaneous, which as dentists we are more prone to such situations. So how do we do the dental management? So patient with active hepatitis should not receive any dental treatment. So these are the strict precautionary measures that you need to take, that patient with any active hepatitis should not receive any form of dental treatment. Emergency treatment can be done only after consulting with a physician. Strict hepatitis precaution must be followed. So if you're treating, then strict hepatitis precaution must be followed. Hand washing before treating the patients, routine use of gloves and protective eyewear, using masks and uniform to protect against the splatter of blood and saliva. The dental chair and the other equipment should be covered with disposable drapes and discarded with every patient. Strict aseptic techniques are to be followed, and heat sterilizing handpiece between the patient has to be done to prevent the spread of infection from the one person to the other patient. All contaminated instruments should be placed in a separate bag for sterilization. It should not, so all the instruments should not be mixed together. A patient who is hepatitis positive, his instruments should be sterilized separately. Operatory must be clean after every use. So now moving on to leukemias. Leukemia may be defined as a group of malignant disease in which genetic abnormalities in a hematopoietic cell give rise to a clonal proliferations of cells. So in simple term, it's a malignant disease and which has some genetic abnormalities, and due to this what happens, there is a hematopoietic, the cells gives rise to other types of cells. So they are the most common malignant neoplasms in the childhood, accounting to about 41% of the malignancies. So the ALL type, that is the acute lymphoblastic type is the most common malignant neoplasm in children, which is seen and which accounts to about 41% of all the malignancies. So we have the different types of leukemias, that is acute lymphoblastic leukemia, acute myelogenous leukemia, chronic myelogenous leukemia, juvenile chronic myelogenous leukemia, and infant leukemia. So acute leukemia accounts for about 1/3 of all childhood malignancies. Of these, approximately 80% are the lymphoblastic or lymphocytic type. That is acute lymphocytic leukemia or ALL. The chronic leukemia is rare in children, which is accounting, that is 2% of all the cases. So 80% basically children will have the ALL type more, while the chronic is rare in children. So the manifestations that we see is anemia, thrombocytopenia, granulocytopenia, increased irritability, lethargy, persistent fever, vague bone pain, easy bruising, pallor, fever, tachycardia, adenopathy, hepatosplenomegaly, petechiae, cutaneous bruises, gingival bleeding. So these are the clinical manifestations that you see in a patient with leukemia. So the dental management of the patient will be primary medical diagnosis. The first important is you need to diagnose the patient, then present the general state of health. Then you need to know about the hematological status of the patient. Then early and radical intervention reduces the risk of oral complication. So you need to have the do early and radical intervention to reduce any oral complications. Every effort is made to reduce the dental disease. So all these efforts include the preventive management of to reduce the dental diseases. Thorough medical should be evaluated for any dental intervention. Basically you need to have a thorough knowledge about the medical history and details about the patient before you start any dental treatment. Infection is the primary cause for death in the children. So pulp therapy in primary teeth and endodontic treatment for permanent teeth is not recommended. So pulp therapy in primary teeth is contraindicated, while endodontic treatment for permanent teeth is not recommended. So routine preventive and restorative treatments, including non-block injections, may be considered when the platelet count is at least 50,000 per cubic millimeters. The use of soft nylon brushes for the removal of plaque is recommended. So what we get to know from this, the dental management, that you need to have a complete history of the patient, diagnosis, the general health of the patient, any bleeding, the bleeding status, the hematological status, any treatment that needs to be done, should be radical, early and radical intervention. Then you need to reduce the dental disease by following the preventive measures. Then any pulp therapy in primary teeth is contraindicated. Endodontic treatment is not recommended. Preventive and restorative treatment can be done, but only can be done, and including non-blocked injection, but the count has to be at least 50,000 per cubic millimeters, and the use of soft nylon brushes for the removal of plaque is recommended. So now we have come to the end of the lecture on special child or children with special healthcare needs. So we mostly have discussed about the medically compromised patient, but coming to a dentist and the dental management, how we need to manage. So you need to know, I have only discussed the most important ones. You need to go through the chapter, read the notes. Maybe there are few mistakes which I can, you just have to read completely, and you have to have a knowledge before you treat any type of patients, especially who comes to our dental clinic. Thank you.